I am one of the pediatric infectious diseases providers at UNM Children's Hospital. And it is certainly my honor and privilege, actually, to spend a little bit of time with you all, giving a quick update on COVID-19 treatment modalities. It's been a phenomenal conference, and way to go for all of you for staying in and getting fed with all of this fantasticness. So I am going to share my screen here. Get this. Okay. All right. So we're going to go ahead and get started. I don't have any conflicts of interest to disclose by any stretch of the imagination, but I am a pediatrician, which means that the lens through which I assimilate things, I present things, really is through one who takes care of children and not adults. And our primary focus today is really going to be to kind of have an introduction into the available COVID-19 therapeutics with a little bit of backdrop that maybe helps us to understand better kind of why we use the treatments that we use and why, we may certainly have changes in the treatments that we use. Additionally, I want to make sure that everyone is aware of the resources that they have available through societies and CDC to find out what they need to take care of their patients. So that's what we're talk about today. And I said, I'm a pediatrician, that is true, but this will inherently be a discussion regarding treatment in adults as well. And why is that? It's because, as with many therapeutics that we use and therapeutic algorithms that we use to treat pediatric patients, most of our data is really derived from adults, right? So when we're talking about this is definitely applied to your adult patients, and then we'll talk about which pediatric patients kind of apply for some of the differing therapies, okay? So I want to extend a sincere kind of kudos and thank you to all of you as frontline providers during this pandemic. Everybody knows, knows that since March of 2020, we have been in the throes of this pandemic, weathering the storm through ebbs and flows of all kinds of perturbations of PPE guidance and testing guidance and all of that. And so I don't think this journey is one that we will soon forget, if ever, during our lifetime. So as frontline providers, certainly everybody in this room has probably taken care of somebody with COVID on varying kind of extremes of the disease, from asymptomatic infections, which make everybody kind of hurt with their potential for exposures and the need for contact tracing and all of that business, to a mild viral-like systemic illness where we may have other organ systems involved, to getting admitted to the hospital and fairly sick with hyperinflammation and end organ damage. I anticipate many of us have seen the gamut of that. So we're not going to spend time talking about that. We don't really have time to talk about that. But I take it that many of us have already seen that. So what we are going to do, though, is spend a little bit of time talking about the structure of SARS-CoV-2 to help us kind of better understand our treatment modalities. Now, before people start to very politely slide away and maybe go find a snack or something like that, because they say, oh my gracious, I did not sign up for a basic science presentation, let me help you rest assured that that's not this. I couldn't even masquerade as a basic scientist. But what I have found is having a bit of knowledge about the structure of the virus helps me to better understand where my treatments work, why the recommendations tell us to start treatments at different times, and why, importantly, treatment guidelines may change and may change fairly quickly based on what is going on with the structure of the virus. Okay, so if we look at this first panel here in panel A, this is our beautiful friend SARS-CoV-2. And this is our beautiful friend SARS-CoV-2 kind of cut in half, right? So if I took this little beautiful spear and cut it in half, I could see inside. And what I see here is a single-stranded positive sense RNA genome, okay? And it is associated with one of four structural proteins, the nucleocapsid protein. It forms a capsid around this genome, and then the genome is further protected by an envelope. And that envelope is associated with the other three structural proteins. There are four in total: the spike protein, the membrane protein, and the envelope protein. Now, many of you may be saying in your head, hey, I know a little something about a spike protein. I am sure that many of us have heard about the spike protein during the course of this pandemic. And there's a reason for that, right? And it's because this spike protein is really important for mediating coronavirus entry into our host cell. So if we look at panel B here, the spike protein is composed of two subunits, the S1 subunit and the S2 subunit. The S1 subunit is really very attractive, and that is because the S1 subunit includes something called the receptor binding domain, or RBD. And you probably have heard that too thrown around during the pandemic. And this is important because the RBD is the portion of that subunit of that spike protein that interacts with the angiotensin converting enzyme 2 receptor, or ACE2 receptor. And so this complex, this RBD ACE2 complex, definitely affects viral infectivity and pathogenicity. And it, along with the spike protein itself, is a very important target for kind of study and treatment development. So what we see here is the S1 subunit is responsible for host attachment, and then the S2 subunit helps us with fusion, or helps the virus with fusion of the viral cells to the host membrane. Now, not to be outdone, there are 16 non-structural proteins, and we're going to give an honorable mention to one of them, non-structural protein 12. And that's because that protein contains the RNA-dependent RNA polymerase. And this is critical for coronavirus replication and transcription. And you say, okay, so what in the world does that mean, and why do I care? And that is because one of our drugs, one of our workhouses, so to speak, attacks that particular protein, polymerase. So it's very important for us to kind of have at least a little bit of a sense of what's going on with the virus. Then when we see something like this, with kind of viral pieces and then drugs everywhere, we don't either glaze over in complete, like, what in the world are you talking about? Or have heart palpitations that require us to seek medical care ourselves. It starts to make a little more sense, and we are a little less intimidated as we kind of think about the treatment modalities and why any of those make sense. I will say that here, this talk really is more focused on antiviral therapy and immunomodulators. But aberrant coagulation is an extremely important component of the damage that we see that is caused by infection with this virus. So managing this aberrant coagulation with appropriate anticoagulants is really important. That's going to be more of an inpatient situation than an outpatient situation. You don't generally have as much of that in the outpatient setting, but the inpatient setting will be nice, and we'll talk about that very quickly in a few slides. So I would certainly be remiss, especially as a pediatric infectious diseases provider, not to mention that vaccination is an extremely important component of our treatment battle against SARS-CoV-2. I know you all had a phenomenal presentation a couple of hours ago about vaccinations. And so certainly as frontline providers, we are going to want to be advocates and educators regarding SARS-CoV-2 vaccination. So before we delve into these treatments a little bit more, let's stop, regroup, and take a look at why we even care about managing this appropriately anyway. So I'm going to stop this share to show you all a quick video. I have to find that. You can bear with me. I am not the best at doing some of the, like, you know, doing the bells and whistles. And so I just have to show you the video separately. I couldn't embed it for whatever reason. There we go. Uh-oh. One more second here. Sorry. All right. This time is the charm, right? There we go.
Hey there, there's no sound. What did
Okay, so I'm hearing there's no sound for this. Okay, so let's. Okay, can you all hear me now then? We will forego the video. It really was one of our little kiddos who was treated and actually did well. So something for everybody to kind of remember why in the world we care about treating, but that we are able actually to affect excellent change if we are treating appropriately. So let's then head back to the talk.
Bye guys, it was good to meet you.
Okay, so this slide really just has a summary of what I like to call our COVID-19 infection treatment arsenal. Okay, and basically there are two big buckets that we put these treatment modalities in. One of them is anti-inflammatory agents, which is further kind of delineated into anti-SARS-CoV-2 antibody products, and then immunomodulators. And then the other one is antiviral agents. And so these are direct antivirals helping us with that replication. And we're going to sit on this slide and spend a little bit of time on this side, because what will happen is we will start to understand, looking at this and talking it through, why the treatment recommendations are the way they are and when it's most beneficial to use the differing agents, right? So what we see here is this top line is pathogenesis, when we're looking primarily at SARS-CoV-2 replication and then SARS-CoV-2 mediated immune response as our major portions of pathogenesis here. And then we're looking at representatives from the different types of drugs and when we might anticipate seeing them. So here on this axis, we are looking at days and symptom onset. So we kind of start at the beginning of our infection. And what we noticed is that in the beginning of the infection, we have quite a bit of SARS-CoV-2 replication going on. So now we've got replication of this virus. And during that time, most of our patients are doing fairly well. They aren't hospitalized. There's no limitation on any of their activities. Like if they're sick, they're mildly sick, but they are otherwise doing okay. And generally, we are doing supportive care at that point. As we move further into the treatment course, people either get better, or if they start to get worse, maybe then we see them becoming hospitalized. And in that instance, we start to see a little less of the SARS-CoV-2 replication and maybe a little more of the immune-mediated response, but often we are still working to stop viral replication and starting something like an antiviral like Rendezvous a little earlier on in that hospitalization. But if they stay hospitalized and have a worsening course, what we see happening is now we have less replication, and instead we have more of the SARS-CoV-2 mediated immune response that is becoming more associated with the symptoms that we're seeing. So in the early part of the infection and hospitalization, we are starting antivirals. As we move ahead and we start to see more of this SARS-CoV-2 mediated immune response, we are adding our immunomodulatory agents to help with that. And that is, sometimes it's a little tricky knowing, hey, am I starting an antiviral? Am I starting an anti-inflammatory? Am I starting both? And this helps us to understand kind of where we are in the setting of the infection and why we start things the way we start. So we're going to focus a little bit here on two kind of workhorses in the COVID-19 treatment arsenal, Remdesivir and then monoclonal antibodies. So we're going to start with Remdesivir. He is not a new kid on the block. We know him from his work with Ebola virus back in 2015. And what we can see here is that early on, he was kind of tapped for the potential to aid in treatment during our COVID-19 pandemic. And so definitely was one of our early drugs to be considered for treatment in this pandemic. And the reason is because he is an adenosine analog that interferes with that here, the viral RNA-dependent RNA polymerase that we talked about earlier in the structure side. And so he is a potent inhibitor of replication in this virus. And so the question becomes, well, is this an effective drug? And if so, is it effective inpatient? Is it effective outpatient? Both? And the good news is it's effective in both. So if we look at this first New England Journal study published back in November of 2020, this was a study looking at Remdesivir for the treatment of COVID-19 in hospitalized patients. It was a series of phase 3 double-blind placebo-controlled trials. And their primary outcome with this particular study was time to recovery. And what they found was those patients treated in the Remdesivir arm had a median time to recovery that was less than those in the placebo arm, with a rate ratio of 1.29. So the effectivity of this drug in the hospital setting was established back in 2020. And more recently, we have had a study that was published in the New England Journal in January of 2020 looking at early remdesivir to prevent progression to severe COVID-19 in outpatients. Gottlieb et al. Published this, and it's known as the Pine Tree study. So you'll probably hear that kind of thrown out, but that is what this study is about. And it's a double-blind, randomized, placebo-controlled trial that looked at the efficacy and safety of a 3-day course. So this is 3 days, not a 5 or 10-day course where we might see in an inpatient setting, but a 3-day course of remdesivir in high-risk, non-hospitalized patients with COVID-19. Of course, of particular interest for those of us who also care for pediatric patients, this did include pediatric patients aged 12 years and older. There weren't very many of them in the study, but it did include them. So that was really fantastic. And all comers in the study had at least one pre-existing risk factor for progression to severe COVID-19. The primary efficacy endpoint was a composite of hospitalization related to COVID-19 and death from any cause by day 28. And what they found was that the risk of COVID-19 related hospitalization or death from any cause by day 28 was 87% lower in the remdesivir group compared to the placebo group, which was fantastic because it established the effectivity of remdesivir to be used now in the outpatient setting. And even better for those of us who care for children, here in the last week, remdesivir has been approved by the FDA to treat pediatric patients who are 28 days of age and older. And this is fantastic for us because we hadn't had that full approval before in this population. And this is for hospitalized or non-hospitalized kiddos with mild to moderate disease who are at a high risk for progression to severe disease. And I love this quote by Dr. Cavazzoni from the FDA, as COVID-19 can cause severe illness in children, some of whom do not currently have a vaccination option. There continues to be a need for safe and effective COVID-19 treatment options for this population. And today's approval of the first COVID-19 therapeutic for this population demonstrates the agency's commitment to that need. And it also demonstrates to our pediatric world that, hey, we understand that the kiddos do need treatment options as well. So we're gonna switch gears and talk about the anti-SARS-CoV-2 antibody uses, okay? And so I think it's good for us to know that these particular antibodies work their action and their magic, so to speak, at that RBD ACE2 receptor complex we talked about a few slides ago. That's their primary mode of action. And placebo-controlled trials have demonstrated the effectivity of these varying antibodies, and it's really fantastic for us to have them. Now, we're going to talk in a couple of slides about kind of their utilization in the setting of variants, which is very important. But here, I will point out that we break them up into kind of 3 categories. The pre-exposure prophylaxis that we see here, which means, hey, I'm someone who is at high risk, potentially an immunocompromised patient who is at high risk for progression to severe disease and may not have mounted a fantastic response to my vaccinations. This is a protective antibody. This is for this column is for post-exposure prophylaxis, which means, hey, I have been exposed to someone who has COVID-19. I have not been diagnosed with COVID-19, and I'm here to provide some prophylaxis in that post-exposure state. And then we have the ability to treat with monoclonal antibodies. I'll say a quick word here about the only preventive monoclonal antibody that we have, the tixagevimab, silgavimab, or Evusheld is its trade name. And what we see from this study, the PROVENT study, looking at this monoclonal antibody for pre-exposure prophylaxis of COVID-19 in adults, was that there was a 77% reduction in the incidence of infection of those in that treatment arm. So establishing itself as a fantastic potential option for protection for our immunocompromised patients. So we said something about variants, and variants are pretty important, especially as we think about treatment options with our monoclonal antibodies. RNA viruses are kind of known to be a little bit messy in their replication, and they often will have mutations. There's a high rate of viral replication, dissemination, and then prevalence all over the place. And this is associated with the emergence of new viral variants, just because those properties are kind of conducive to forming mutations in their genome. And very interestingly, we often see mutations occurring in the spike protein. And if we can recall the mechanism of action where these particular antibodies tend to work is there in that spike protein. So if we have lots of mutations within the spike proteins, what we could anticipate potentially happening is the development of a lack of effectiveness, so to speak, in our monoclonal antibodies. And that's exactly what we see. Here, this right here is just a nice schematic that shows during the pandemic just how many variants we have seen over time in the pandemic. Currently, Omicron is our dominant variant in the United States. This is from the CDC, and I put the link here. You can go to this. It's really excellent. As of 4/23, we see here that Omicron BA2 was taking hold and becoming our most predominant strain, and that affected our utilization in monoclonal antibodies in a big way. So here, this chart shows us that really the only monoclonal antibodies we have currently available to help us with our fight in the Omicron with the Omicron BA2 variant is the pre-exposure antibody, the tixagevimab, silgavimab, or Evusheld, and then this treatment antibody, which is the vedlotovimab. Okay, so those are the only two, and you probably have heard about sotrovimab and casirivimab and devimab and bamlanivimab, etesivimab. Currently, we are not using any of these because they don't retain activity against Omicron BA2. So let's talk about guidelines here. These are just some clinical scenarios for us to consider. We're not going to walk through all those. We don't have time. It's more to just let us think about the differing types of patients that we might have. You can add a few years if you want to make them adults. It doesn't really matter. It's the clinical scenario that is important. And then the frameworks we're using are from NIH. So this is NIH COVID-19 treatment guidelines. I will also let you know that the Infectious Diseases Society of America, or IDSA, has treatment guidelines that they have published as well. So they are another resource that you can use to help when you are trying to figure out what to do with your patients. So here, this is in the outpatient setting that we are looking at. This is in patients who, this top kind of clinical category, patients who don't require hospitalization or supplemental oxygen. If you're at a high risk of progression to severe disease, these are our current options, right? So in order of preference, Paxlovid, which I anticipate lots of people have been hearing about here recently, or Remdesivir. Those are the primary treatment modalities you're going to use in somebody who is COVID-19 positive, but doesn't require any support really, but they're at high risk of progression. If you can't do those, then at least at current, bebtelovimab and molnupiravir are other options. Now in the peds world, our older kiddos can get Paxlovid. As we saw in the slide a few slides ago, our younger kids even can get Remdesivir. Our older kids can give bebtelovimab, and then molnupiravir is only for adults. Now it's important for us to know that we don't use steroids routinely in this population. Sometimes people will ask that. unless there's another indication for it. And it makes sense, right? If we go back over to here, our pathogenesis, why we really wouldn't need to use steroids, right? We're in this early stage where really what we are trying to combat is SARS-CoV-2 replication, and we don't tend to have as much of the SARS-CoV-2 mediated immune response that's kind of causing this this extreme clinical scenario here. Okay, if we are discharged from the hospital inpatient setting and we're stable and we're doing great, there's really not a need to continue anything as an outpatient. If you're discharged and you still require some supplemental oxygen, often we are determining those on a case-by-case basis in a multidisciplinary sort of strategy to figure out if someone still needs something as an outpatient. And then if we are discharged from the ED despite being kind of sick and getting sicker, of course, this is going to be crisis standard, right? We're not in that, thank goodness, anymore. But this is talking about a situation where you just don't have room. You just can't get them admitted. Certainly, you would want to start those patients on steroids, and you would consider if you could do something like Remdesivir, right? There's a caveat, and I think it becomes a little tough for them to make a formal kind of declarative recommendation, because sometimes it's hard to operationalize giving Remdesivir as an outpatient. So you certainly could consider that in that clinical scenario. Now, if we transition to hospitalized patients, here is where our anticoagulation comes into play. Again, that aberrant coagulation, we've got to make sure we are addressing that and treating that appropriately. If we go here with our antiviral or immunomodulator therapies, if you're hospitalized, but you don't really require much in the way of supplemental oxygen, it's similar to that outpatient setting. There's not a routine recommendation for those patients to be started on steroids either. And they don't necessarily have enough information to say that they definitely should be started on something like Remdesivir. But if you are a high-risk patient, and so this is important for us to know, sometimes actually we have patients who are hospitalized for something else, but they are COVID positive and they're at high risk for progression to severe disease. Those patients could get Remdesivir as an inpatient, right? So here, this study was published prior to our latest data showing Remdesivir as effective therapy with a 3-day course in those high-risk patients as an outpatient. But here, Remdesivir really can span the pathogenesis kind of threshold here from the beginning until you're hospitalized in the higher risk patients, right? So Remdesivir in high-risk patients would be a great option here. If you're hospitalized and you require supplemental oxygen, you can either do Remdesivir alone, steroids alone, or both. From our standpoint, it's our practice and standard of care to do both. So we always start with dexamethasone and Remdesivir if now you have an oxygen requirement, okay? If you have a patient who is on steroids, right? Or they can't be on steroids and they have a rapidly increasing oxygen need, so their respiratory support is going up and they have evidence of systemic inflammation, you're going to want to add another immunomodulator, something like baricitinib or tocilizumab, right? So those are those in that immunomodulator group. For us, we generally will start something like baricitinib in the pediatric population. But many of the patients will be on a dexamethasone, Remdesivir, and baricitinib combination if they're admitted, and then they have this kind of rapidly increasing respiratory support and inflammation. And then here, what we notice in these kiddos, or adults, I should say, toward this kind of higher respiratory support, where now we're using high flow devices, or we are needing mechanical ventilation or ECMO, we have now moved into this kind of SARS-CoV-2 mediated immune response, where that is primarily what we're seeing. And so anti-inflammatory agents kind of take over as the treatments, of course, that we definitely want to make sure we are starting. And then remdesivir is often kind of plus or minus. Now, I will say that for us, most of our patients, they don't come in, at least in the peds world, they don't come in kind of admitted needing something like ECMO or even mechanical ventilation. So most of our kiddos are coming in somewhere, anywhere in here, and they're often started on remdesivir before they would need something like mechanical ventilation or ECMO anyway. So, if you had a patient coming in closer to here, it would be a discussion regarding whether you would want to start remdesivir. Because remember, once we are further into our treatment course, or excuse me, into our clinical course, we have less replication. And so the question becomes, is something like remdesivir even as helpful? So of course, as a peds IV doc, I have to say a word about multisystem inflammatory syndrome in children, or MISC. There is a similar clinical syndrome in adults, but from my standpoint, MISC is what we tend to treat. And then this started in the UK. It kind of burst on the scene in the UK in April of 2020. And then fast forward to now, and cases of MISC have been reported worldwide. And it's a little difficult to diagnose it sometimes. It's a syndromic diagnosis, and we don't have a gold standard. So I don't have one test I can do that tells me, oh, okay, I absolutely have MISC. We're still trying to work to understand the pathophysiology associated with MISC, and there's multiple definitions kind of across countries. They have different ways they define it. Here at the CDC in the United States, the CDC's definition is an individual aged less than 21 years who has fever, has laboratory evidence of inflammation, is clinically severe enough that they require hospitalization, and then have multisystem, which is defined as greater than or equal to 2 organ system involvement. So I'm gonna let everybody think about that for 2 seconds and let it sink in. And then you're gonna say to me, okay, well, isn't that just about every pediatric patient that comes in, especially during viral respiratory season? And you start to glean a little bit of why this might be a difficult diagnosis to make. But again, it's syndromic and has multiple parts. There's no alternative plausible diagnosis, and the patients have to have some evidence of current or recent infection with SARS-CoV-2, or kind of a known exposure to a suspected or confirmed COVID-19 case within the 4 weeks prior to the onset of symptoms, which can sometimes be tricky, right? Because we, in times of high community spread, that may be in something that happens and people don't really know that they've been exposed. I love this study that was reported from the MMWR in August of 2020. This is when, by Gottfried Cato et al., this is when we were trying to really determine a little more about MISC pathophysiology. And it was very interesting. They found kind of 3 cohorts of patients, so to speak, and almost a third. The first class they were a little bit older than some of our kids with Kawasaki disease, and we're going to talk about that here, who may be admitted prior to COVID. Median age was 9 years, and these tended to be the sickest, right? So these kiddos had the highest number of organ systems involved in their presentation. They were fairly sick, had things like shock and myocarditis, and really were elevated as far as inflammatory markers were concerned. And most of these kids, just about all of them, had positive serology indicating they had had previous infection with SARS-CoV-2. This second class, median age was 10 years, and these kids were kind of interesting. A greater majority of them had actual respiratory symptoms with a highest kind of case fatality rate. And more of these kids, 84% of them, had positive PCRs without positive seropositivity, meaning they didn't have any IgG there. And so the question is, were those kiddos actually true MIS-C, or were they more kind of subacute, longer standing COVID? And then this class, the third class, they were a little younger, median age 6 years, and these kiddos tended to look more like our traditional Kawasaki disease kiddos. And 63% or so of them had positive serology only, and about a third of them had both positive serology and PCR. And when we think about MIS-C, it is really thought to be a post-infectious phenomenon, right? And not active COVID-19. And we're going to see why that makes a difference in our treatment guideline here in a second. Our most recent data per the CDC, we've had since those cases reported on or before March 28th, almost 8,000 cases of MIS-C. And thankfully, not many, but it's not zero deaths associated with MIS-C. So still demonstrating that COVID-19 can cause severe and does cause severe infection and post-inflammatory change in our, much like Dr. Hayes' talk with long COVID, right? We still do see those things happening in people. So here with our treatment guidelines for MIS-C, what you will note immediately compared to our treatment for COVID-19 is that immunomodulation is what we are focusing on here, along with antithrombosis, which is common to treatment even with Kawasaki disease. What you see kind of absent here is the utilization of Remdesivir. And it makes sense that we wouldn't use Remdesivir in these patients because they're not thought to be actively infected. They're thought to be affected by their previous infection with COVID-19. So to end things here, the takeaways, the treatment modalities continue to change as we learn more throughout the pandemic. Always consider the current epidemiology in your area as it relates to variants, because it may influence the effective treatment options. Currently, we have Remdesivir, we have Paxlovid, we have Molnupiravir, and Bebtelovimab as our treatment options in the way of antivirals and immunomodulatory agents. And we should always continue to encourage vaccination. So thank you very much for allowing me to spend a little bit of time with you all to talk about COVID treatment. And I don't know how much time we have for questions, if there are any questions. And I'm always happy to be emailed with questions if you have those later as well. Does anyone have any questions to put in the chat? Or if we have people who are still in the ballroom, happy to take those questions as well. Okay, well, wonderful. Thank you very much.